1 in 8 men will, during their lifetime, develop prostate cancer.
What are some symptoms that should raise concern for men?
It does not have any symptoms, so you won't feel anything. You'll feel completely well, but blood out of any orifice is bad news, and you need to get checked up.
Why is there so much stigma attached with discussing prostate-related symptoms and prostate disease?
So people are scared to get diagnosed and get treated. Some men who come see me in the clinic will say a life without sex is a life not worth living.
Are we doing too much by aggressively treating early-stage prostate cancers?
You can have a high PSA and not have prostate cancer. And some of the studies that we've done using MRI have shown that you can have a low PSA and still have a clinically significant prostate cancer.
If I or you were diagnosed with prostate cancer, would you want to have a prostatectomy?
My father was diagnosed with prostate cancer. He said, absolutely no way, I will not go under the knife. Do I really need an operation?
Professor Prabhakar Rajan, thank you so much for being on this podcast and joining me today.
Thank you, Dr. Rajan. There's one Rajan interviewing another Rajan.
Yeah, this is you are the first Rajan that I've had.
That's amazing.
It's not a very, very common surname, certainly in the UK. So it's good to be face to face with another Rajan. That's
Absolutely.
not my dad.
Privilege to be here.
Now, you're a urologist. You're also a specialist in prostate health, prostate cancer. There's a lot of men's health topics which aren't spoken about much. And a lot of that is because men don't bring up these topics. Men don't flag these symptoms. But also we could argue that the healthcare systems are not designed appropriately to adequately take care of men's health needs. I want to focus on symptoms in general, reproductive health and prostate and testicular health. I mean, there are discrete topics, but a lot of overlap. What are some symptoms that should raise concern for men that they should go and see their doctor?
So, as you've described me, I'm a urologist, and my specific expertise is in urological cancer, specifically prostate and testicular cancer. So if we sort of focus around those two cancers initially, but we can talk about other cancers as well. So the main point to make is that prostate cancer being the commonest male cancer, 1 in 8 men will, during their lifetime, develop prostate cancer, and 1 in 4 in some individuals who are at high risk, is a asymptomatic condition. That means it does not have any symptoms. So you won't feel anything. You'll feel completely well. And someday a doctor might tell you, well, you're at prostate cancer risk or you've been diagnosed with prostate cancer. But there are some symptoms of advanced prostate cancer that are really important to look out for. So these would be instances where the cancer is spread to other parts of the body. So for example, back pain, that isn't just your usual, been working too hard in the garden, doesn't go away with normal painkillers. And in leg numbness or weakness, these might indicate that the cancer is spread to other parts of the body and should absolutely not be ignored. Other symptoms might be that you are having issues with urination. Now, the problem is prostate cancer generally affects older men. Urinary problems affect older men, so that may not necessarily be the case. But if, for example, you go into complete retention of urine, you're not able to pee at all, then you need to seek help. And blood in the urine is really important. Not that it's necessarily a symptom of prostate cancer per se, but it's really important to get checked out. Blood out of any orifice is bad news, and you need to get checked out.
I mean, people often say that prostate cancer is something that men die with rather than from, predominantly. There's a lot of people say that because it's a very indolent, slow-growing cancer, and it's not an emergent cancer like a bowel cancer, which can cause a bowel obstruction and, various other things and metastasize quickly and spread quickly. What is your take on that? Because, clearly there are, prostate cancers which are aggressive and different subtypes and can cause problems for sure. But in the vast majority of cases, does it still hold true that it is more a cancer of old age that is unlikely to kill someone, but, just with old age, it will develop and then someone will die from another cause, and then post-mortem, they'll be found to also have prostate cancer? Yeah,
and the historic studies have looked at prostate post-mortem and have found up to 80% of men will have some, at the age of 80, will have some underlying prostate cancer. It may not necessarily be, as you described, an aggressive type. So that's where the controversy lies in, for example, as you've described, the absence of a screening program in prostate cancer, is that it does have a latent, a non-aggressive stage. But having said that, we haven't got an increasingly aging population. The largest growth area amongst men in the UK is over the age of 75. We've got an aging population. Since prostate cancer is age-related, it's becoming a more and more of an issue. The other point to make is that we're living longer because we're better at treating conditions such as heart disease, which previously people would die from at quite a young age. So yes, I think historically we were always thinking, well, you die with a disease rather than because of the disease. But that's changing as the population ages and as we're able to better look after ourselves as we get older.
There was a meta-analysis done a few years ago which essentially suggested that for, slow-growing prostate cancer, which hadn't metastasized in the early stage, there was no significant difference in mortality between close surveillance and observation, active surveillance of a prostate cancer versus a robotic prostatectomy to remove it, which may suggest, based on that snippet that I've suggested, that are we doing too much by aggressively treating early stage prostate cancers, which many people do all over the world? And also when it comes to the surveillance aspect as well, is it maybe opening Pandora's box where, we sort of over-investigate, over-surveillance and over-treat, because we know that the prostate is in such an intimate area surrounded by all these nerves, pelvic floors and, other structures. Can it cause more harm, us aggressively treating something like that?
So I'll go back to your first point, which was the comparison between different treatment sites for early prostate cancer and the lack of evidence for a strong difference in the benefits of treating the disease. So, one of the landmark studies that was undertaken in the UK is called the Protect trial, where they took men who were screened for early prostate cancer, and the men were randomly allocated into surgery, radiotherapy, and active surveillance. And the survival outcomes, as you just described, are the same. So that's a really important study, because what it means that if you are diagnosed with early disease, you may not necessarily need treatment. That might mean that you're spared some of the horrible side effects that you have just described, urinary incontinence and impotence. But the important point to note is that particularly in younger men with very early non-aggressive disease, they do need lifelong monitoring. So we want to avoid diagnosis of men who, in those individuals, their prostate cancer is unlikely to affect how long they live. And the second point to make is that we want reliable ways of monitoring these men, because a proportion of them will progress and need radical treatment. So that's where the point comes about better diagnostic tests, screening tests for prostate cancer. And one of the things that's really transformed the way that we manage prostate cancer is the use of MRI scanning. So we can use MRI scans to actually visualize early tumors within the prostate gland, and very early stages of the disease, so microscopic cellular levels, may not actually be visible on an MRI scan. We can say, fine, we're not so worried about these men. Let's just monitor their PSAs and see what happens. On the other hand, men who have small tumors, they may need a biopsy, and that biopsy may lead to a diagnosis of a cancer that may or may not need treatment in the early stages. But there are also different ways in which we can treat the disease that avoid some of these horrible side effects that you've been talking about.
Why is there so much stigma attached with discussing prostate-related symptoms and prostate disease?
So I think there's sort of a couple of points to make here. And I think number one is the side effects of treatment. So people are scared to get diagnosed and get treated. One, because of the risk of incontinence, losing your control of the urinary function and also your sexual function. Some men who come and see me in the clinic will say a life without sex is a life not worth living. The second point, and this is to dispel this myth, is a lot of people still think that you need to do a finger test of the prostate gland up the back passage to diagnose or to rule out a prostate cancer. That is out now. You probably remember when you were at medical school, you were taught if you don't put your finger in it, you put your foot in it.
Yeah.
And that's no longer the case as far as urological cancers are concerned. Early prostate cancer is typically, you can't feel it on the finger test. And that's why we're using MRI scans more and more to actually identify these tumors. And that puts men off, because they think, I really don't want a doctor examining my prostate. And in some of the work that we've done in East London, particularly amongst the African and Caribbean community, there's a real stigma associated with the finger test. And, this goes back several generations. And So I think that's one bit of it.
Just to touch on a point you mentioned there about, sort of certain ethnic minorities like black men. I think it's well established now that ethnic minorities, especially black men, have a significantly higher chance of being diagnosed with advanced prostate cancer and also die from prostate cancer as well. Do you think that's because the healthcare systems are not effectively designed for men, especially men of color? But also, is there anything genetically, from a genetic profile point of view, which raises someone's predisposition towards prostate cancer in those groups?
So it's a really good point, and we don't really know the answer to that question. So black men, as you've described, have got a 1 in 4 lifetime risk compared to a 1 in 8 lifetime risk, a significant increased risk. They're diagnosed at a younger age. They tend to be from more deprived backgrounds. There is a link between ethnic background and social deprivation within the UK and also internationally as well. And they, as you describe, are at a higher risk of dying from the disease. So there's probably a genetic element to this. We're not entirely sure what that is. Prostate cancer is highly heritable. So in other words, your risk of developing prostate cancer, you unfortunately have to blame your parents, like for lots of diseases. And it's not just typically a single gene that's important. It's a whole series of genes. It's polygenic, as we call it. So that's an important point to make. And then when you talk about the healthcare systems, unfortunately, historically, we haven't served men of African and Caribbean background particularly well in terms of healthcare provision. And they do, unfortunately, encounter barriers to health. It feeds into, unfortunately, a mistrust of Western medicine and Western healthcare. We need really strong role models in primary and secondary care. You're much more likely to trust and believe a doctor who looks like you, or any other healthcare professional for that matter. So it is a challenge. And I'm really hoping that some of the new government policies around men's health and last year's first government white paper on improving men's health will hope to change that.
Only 5% of us are feeding our guts properly. That means 95% of us are accidentally starving our microbiomes, and we feel it through bloating, sluggish digestion, and other symptoms and health challenges. That's why I created Loam, a 6-in-1 prebiotic fiber blend designed to cultivate a nourished, thriving gut. Each serving delivers 10 grams of plant-based fibers, making it that much easier to feed the gut bacteria that fuel your digestion, immune system, metabolism, mood, and more. And the best part is it's completely invisible. No taste, no texture, no grit. Loam dissolves into anything and literally disappears into your day. If you want your whole health to thrive, start by feeding the ecosystem that runs the show. Head to www.loamscience.com to try Loam. And exclusively for you, just because you're listening to this podcast, get an additional 10% off with the code POD10. Again, that's POD10 to try Loam and get an additional 10% off. Loam, health grows here.
For years, people have relied on the PSA, the prostate-specific antigen test, to almost be, like this herald of something going wrong with the prostate. And it seems like a test which is not highly specific, but very sensitive. And it can have a lot of noise and false positives with various things. It can go up with age, inflammation, infection. Any other systemic causes can also contribute to that. And it's not necessarily a signal that someone has prostate cancer. And maybe it's better for tracking someone who's got a cancer and sort of the up and down, results of that. Why have we still not developed significant population-based tools beyond the PSA to actually provide some sort of surveillance? Because, going back to the earlier point, it may not be something which is an acute cancer which someone needs to deal with within days or weeks or even months. But, in some cases, it still needs to be managed, and surgery might be an option, radiotherapy, all these may be options. So given all of, the complications that can arise with prostate cancer, why still don't we have better tools? You said MRIs are coming more and more into fashion now, but why still this long lag until we've got to this point?
We do have some tools, and you mentioned MRI. They haven't been tested in population-wide screening studies as yet. one of the challenges with prostate cancer, because of the fact that it's not a very aggressive tumor, it takes a long time to actually show benefit from things like screening strategies. And even the best study that we've got so far with the longest follow-up, so 23-year follow-up European screening study using PSA, showed a benefit for screening, 20% reduction in mortality for screening, but it took 23 years for that data to mature. And there is a risk of overdiagnosis. So for 500 men screened, you need to diagnose and treat 12 cancers before you can save one life from prostate cancer. So the other point is that MRI has really transformed the way that we diagnose the disease, but it hasn't been used as yet in a screening setting. There is some early data which shows that if you screen with MRI, about 50% of those men will have low PSAs. A PSA is under 3. So we need to test that in larger scale studies. And the Transform trial, which we spoke about earlier, is looking at incorporating MRI into a screening strategy. The second point, which goes back to what we discussed about genetics, is what we describe as a polygenic risk score. So your risk of prostate cancer is inherited, as I described, from your parents, and is due to multiple different spelling errors within genes. And it's the cumulative impact of all of those genes that increases your risk. It's not just one gene for the majority of patients, although there are some high-risk genes that are inherited, the BRCA gene, for example. So what the Transform trial is also doing is to look to see whether these polygenic risk tests can help to risk stratify men and identify which patients need to go forward for screening using an MRI scan. So there is work in this space. Yes, we need to do more and we need to get on with it. But there is stuff that's ongoing nationally to look at this in more detail.
I guess with most cancers, the general rule of thumb is the earlier you catch it, the better the outcomes. Does that still hold true for something like prostate cancer, where it is so indolent and so slow growing? Does it really make that significant of a difference in terms of health outcomes on a population level?
Early diagnosis does save lives. It saves lives across a number of different cancer types. But I think the point you make earlier on is that because prostate cancer is often identified in older men, identifying a cancer may not necessarily change how long they live. So you need to screen the right people. There's probably not a huge point in establishing a screening program for the over 80s, because even if you had a metastatic prostate cancer, you're more likely to die from something else than you are from your prostate cancer. So identifying the cancer early in the right group of patients is really important.
And, the PSA, it's sort of been maligned a lot over the years. Why is that? And why has it been so controversial?
As we spoke about, the fact is that you can have a high PSA and not have prostate cancer. So there are things like urinary tract infection, trauma to the prostate. So cycling, for example, can put your PSA up. Ejaculation, other sexual activity can put your PSA up. So you can have a high PSA and not have cancer. And some of the studies that we've done using MRI have shown that you can have a low PSA and still have a clinically significant prostate cancer. But it's not a perfect test. It's cheap. It's readily available. The second point is that historically we have been diagnosing and treating men based on the PSA levels alone. So that would mean that we'd find cancers that are very early grade, non-aggressive, and then we treat them radically. People like me were cutting out prostates, rendering a lot of men impotent and incontinent, which is not a good thing. So on the basis of that, PSA got a bad name.
And do you think, the problem is that it's good and bad, or clearly, depending on how you use that data. At what age should men start being screened with PSA, for what it's worth?
So the guidelines are a little bit unclear in the UK. And we're talking about individuals who do not have any symptoms. So for that group of patients, the guidelines suggest you can have a conversation with a GP about a PSA test. Any man can do that from the age of 50. Now, you could argue that if you're at higher risk, that conversation should take place a little bit earlier, perhaps at the age of 45. And certainly the European guidelines suggest that that would be a good age group to consider going forward and having a chat about risk. But it's a difficult conversation for all the reasons that we've described, because the test that you're going to use is a PSA test. And a high PSA doesn't necessarily mean that you've got an underlying prostate cancer. And so that's why it's really important to at least have the conversation, decide whether or not the test is necessary, and go from there.
You mentioned before about in this sort of transform trial, you're looking at a combination of different diagnostics, including, looking at someone's genetic risk as well, as part of the risk stratification to decide, which bucket of treatment or which algorithm they should fall into. You've obviously done a lot of work looking at the genetic basis of prostate cancer and the biology around that. What did you learn that's sort of, clinically translatable and applicable to people?
So my work was mainly around some of the early biology of prostate cancer. It wasn't looking so much at the translation. So this was what we call discovery science, trying to find new ways to understand how prostate cancers grow and spread to other parts of the body. So I was looking at a process called alternative splicing. So historically, we always thought that one gene led to one protein, and that protein went off and did something in the cell. Caused the cell to grow and spread beyond the body. But what we found is that the genome, so the sort of collection of genes that we have within the human body, are actually much more complicated than that and can change and adapt in different ways when they're actually trying to execute their function. So one gene can lead to multiple proteins, and those proteins can do different things within the cell. So that's the process I was studying, and it's a process that's actually part of normal life. It creates variability in life, but it also creates variability in how cancers behave.
Now, maybe a bit of a personal question, and touch wood, it happens to neither of us, but if I or you were diagnosed with prostate cancer, would you want to have a prostatectomy?
It's a really good question, because my father was diagnosed with prostate cancer about 14 years ago, at the age of 76. And it was fairly aggressive cancer. And of course, as a surgeon, I had a total bias in the way I felt that he should be treated. And I thought he should have surgery. Fit guy, no medical problems at all. And I took him to see the surgeon. I took him to see the oncologist. He said, absolutely no way. I will not go under the knife. Stay away.
That's what he said.
That's what he said.
Yeah.
He said, stay away from me. I'm going to have radiotherapy. He's now 91. He's absolutely fine. So I think it depends. It's a really personal decision. And it depends how old you are and what your priorities are in life. So whether it's cancer cure, whether it's maintaining your sexual function, whether it's maintaining your continence, it's a really personalized decision. That's what's changed now in our clinic consultations, is we will take into account all of these different things rather than just recommending a one-size-fits-all treatment. We'll personalize that decision.
I had a bias, or I have a bias for surgery in the other way. So, from a general surgery perspective, the things I've seen, the things I've done, I've seen colleagues do inside the abdomen, it pushes me away from ever wanting emergency or elective abdominal surgery or bowel surgery, if I can avoid it. And I'm not thinking about, acute things like a bowel cancer, but I'm thinking about, sometimes acute things like if I was diagnosed with appendicitis, and it was an uncomplicated appendicitis, I would take antibiotics. I would not have surgery unless it recurred. If I have a small hernia, I will do anything to avoid hernia surgery because I know the risk of chronic groin pain and all of these other things. And I've seen sometimes, how gnarly and aggressive it can look, putting in a mesh and all these sort of things. So interestingly, I had the bias the other way because I've seen from one side of the fence, if those medical conditions, if I had them, I actually would do anything to avoid it.
And I think surgery has changed now. It's been 20 years since I was doing general surgery, and we were pretty trigger happy with opening an abdomen and operating on all sorts of things. But the way you manage, for example, diverticulitis, a fairly common inflammatory condition of the bowel, has changed now from going in there and ripping out somebody's colon to treating it conservatively, as you're describing, with antibiotics. And similarly with a peptic ulcer, a perforation in the gullet, and that in itself can be managed without operating. So things have changed. And of course, unfortunately, surgeons have got a bad name from being a bit too eager to operate, and sometimes moving away from that and having conservative approaches is better. Some instances, you just need to get on in there and sort it out.
Do you think, clearly there's sometimes a disconnect between what a surgeon wants to do, what is the right thing, and then translating their thoughts to the patient. And that often is where the unhappiness and disconnect often happens, where the patient doesn't feel fully informed and feels they don't have autonomy in that decision, even though it may have been the right decision by the surgeon, but it leads to some, unpleasant post-surgery feelings potentially if there were complications or, the scar's not right or whatever. If a patient is about to have a prostatectomy, a robotic prostatectomy, or some sort of prostate surgery, what should they advocate for? So if I was the patient sitting in your clinic, what are some questions that I should be asking so I'm fully content with, things at the end of surgery, and things I should be mindful of, especially bearing in mind that there is a higher than average risk of sexual dysfunction, and other urethral issues and so on.
So I think what's really important, first of all, is do I really need an operation? Is there any other way that this condition can be managed? And we talked earlier about active surveillance. Some tumours, early tumours, can be monitored. And I certainly think that if I was in that position at my age, at least, I wouldn't be wanting to rush in there and have an operation. I'd be thinking about active surveillance. How can I avoid surgery for as long as possible? And some of the work that we've been doing on the research side is to look at ways that we can actually improve active surveillance. How can we reduce the risk of that cancer progressing? Is there any diet, exercise, any kind of supplements we can take to improve that? So that's one part of it. The second part of it is that some early tumours that are just in one area of the prostate gland do not require the entire prostate to be removed. So you can treat that one area using an approach called focal therapy. So that involves using either ultrasound to heat up the tumour and kill the cancer cells, putting a needle in and freezing the tumour, or a newer technique is putting needles into the tumour and are actually electrocuting the tumour itself to kill off and burst those cancer cells. And some of the early data that we have now on focal therapy shows that it's very effective, not only in cancer control, but also in terms of maintaining some of the functional outcomes following treatment. And then there's also options in terms of radiotherapy. Radiotherapy has become very focused, targeted to actually treat the tumour, avoid the side effects around the gland. So I'd want to know what are the alternatives. And then in terms of surgery itself, there are some approaches that reduce side effects. So one is nerve-sparing prostatectomy. So the nerves which control your sexual function, they run like a hammock around the prostate gland. You need to peel those nerves off to get the prostate out. And unfortunately, they get damaged in the process, and that can reduce your sexual function, cause shortening of your penis, and stop you ejaculating normally. That's pretty bad for a lot of young men. But nerve-sparing prostatectomy may, in some instances, reduce the risk of that happening. The trade-off is that it may increase the chance of leaving cancer behind. Yeah. And there are newer approaches, something called NeuroSafe, which is frozen section analysis. So at the time of the operation, whilst the patient is asleep, we take the prostate out, we slice it up, we look at the margins and make sure that we've got all the cancer out. And if we do that, we can go a little bit closer to the prostate than we perhaps would have done, and that will improve the chances of sexual function. Of course, if we end up leaving some cancer behind, the pathologist will say, hey, look, go back in there and take that bit out because we're concerned there's something left behind. The other approach, which is quite interesting, is something called radiotherapy prostatectomy. So normally when you take the prostate out, you take it out from in front of the bladder. The bladder sits just behind the pubic bone and the prostate below that. So you have to disrupt some of the structures around the bladder to get access to the prostate and take it out. A bit like, I guess, fiddling with the engine with the bonnet open. But instead of doing that, what you can actually do is go underneath the car, so behind the bladder, and take the prostate out that way. And there's some data to suggest by doing that reduces the risk of you being incontinent after the surgery. So there are a few bits and pieces that can be done to tweak the surgery to make it a little bit better, optimize it, as it were. And what we do nowadays is we look at the MRI scan that's used for the initial diagnosis, and we plan the treatment of the patient, the surgical plan, before the patient has surgery to try and optimize the outcome.
Now, say someone did have some, nerve-related issues and that it affected their libido and, ejaculation, sexual function, and even urinary function post-surgery. Focus more on the sexual side of things. What are some options that can be done post-surgery to kind of improve the state of that?
So libido isn't usually affected because we don't affect the testes. So the testes are the things that produce testosterone and give you your sexual urge. Unfortunately, your ability to get an erection is affected. And generally speaking, what we do is to start fairly early on something called a PD5 inhibitor. So commonly known as Viagra or Cialis. They're taken usually on a daily basis, sometimes a couple of times a week, and that increases the flow to the penis. It maintains penile length, and it can help maintain that function. So that's number one. Number two, we encourage patients, in some instances, if that doesn't work, to actually inject the penis with a drug that increases, again, flow in the area. We get them to use a pump device to improve flow. And in the worst case scenario, and this is not that common, but sometimes happens, is that we have to actually put an implant into the penis itself. Sexual function recovery after prostatectomy can take a couple of years. It can take a couple of years for those stunned nerves to restore their function, or perhaps even regrow. We don't know what happens exactly because nobody's really studied it in the longer term. And so we normally wait a couple of years and try all of the alternatives before we go for surgery. An implant has been the sort of final chance.
Now, just changing gears slightly, but still in the same sort of realm, is testicular cancer. I think maybe not too many young men are aware that, men under 35, it's, the most common cancer. It's the number one cancer for men. And, it's the silver lining, I guess, is that when it's caught early and dealt with, there's a 97% survival rate, which is pretty high as cancers go. But what should men know about testicular cancer, young men?
So, as you've just described, it's the commonest cancer in young adult men. It's highly curable when caught early, and it is easily checked for. Unlike prostate cancer, which is an organ deep inside the pelvis, your testes are there, ready to be examined. So what we recommend is that in basically post-pubertal children, so the earliest testicular cancer case that I've come across is sort of the age 15, 16, you would be wanting the boys and young adult men to examine themselves at least on a monthly basis, checking for any new lumps and bumps in that area and seeking medical help if they find something. And, fortunately, testicular cancer is still a rare cancer. Some of these lumps and bumps will be benign things, and so is a simple ultrasound, a jelly scan of the scrotum is enough to say, look, it's fine, nothing to worry about. Don't worry about it.
Yeah, typically, I guess the most common symptom that someone will experience with testicular cancer is a painless, palpable lump.
That's right.
That they'll feel. Is there anything else that you typically see apart from that?
So in the cases of advanced disease, and again, this is really uncommon, some patients can have back pain. And the reason for that is that testicular cancer spreads to the lymph glands at the back of the abdomen, along the big blood vessels that sit at the back of the abdomen. And if that happens, that can give you a sort of a dull, dragging back pain. Fortunately, the metastatic disease isn't so common. It's usually a painless lump.
And would you say it's fair to say that in most cases, in almost all cases, if someone notices a lump that was painful, it's most likely going to be reassuring that it's unlikely to be a cancer? I mean, sure, you get checked out, but
I think I would prefer, because sometimes there's a trigger for you to examine your testes. So, I don't know, for example, you're playing football and you end up with the football in your testicles. You might think, actually, there's something it's painful. But it might have been the football that hit it, and it was actually a painless lump before that you had noticed. So I think if we put it that way, I would be concerned it would give some false reassurance and discourage people to come forward. I want to see anybody.
Yeah, you want to see anyone with a lump. Yeah. What is the likelihood of seeing a cancer that was, started and originated as a painful lump?
Oh, that's a really tough question.
Just typically in your own experience that you've seen in patients, like, have you seen many of them?
No, they're usually the painful lumps, generally speaking, are associated, I don't know, with infection or something else. But I wouldn't want to say just because you could also have an infection and have an underlying tumor.
Yeah. I think one of the barriers to most men picking things up when it comes to, testicular health would actually just be basic anatomical understanding. And I don't know at what point, men are taught these things, because I certainly growing up was not taught, the basic anatomy of the testicle, the epididymis, and it's a cord that's slightly knotted and it runs through the back. And, this is what to look for. If you were simply breaking it down to men, similar to how women are taught to self-examine and the clock face of the breast and palpate in different areas. Number one, what are the basics of testicular anatomy that they should be aware of, and then translating that into sort of lay speak, the epididymal cord and the vas deferens and the actual testicles, versus also then how to go about examining it?
Okay, so it's a really good question to ask, because actually I just bought some plasticine the other day in the hope that I would create a model to put something on social media around this, because I agree with you, it is difficult to understand and difficult to explain. So I wish I'd brought my model along. Anyway, it's fine. So the testis itself is an ovoid structure, and it's got a smooth covering to it. It sits at the front of the scrotum. So the scrotum, obviously the bag that contains the two testes. And then behind, so the testis is the thing that produces the sperm. It also produces hormones as well, produces testosterone, the hormone that's given you that fabulous beard that you're wearing today. So, and then behind the testicle, there are some structures, the ancillary structures that help with transport of the sperm and maturation of the sperm, making it suitable for fertilization up through the groin area and then out through the penis. And that one of the tubes is called the vas deferens. We know it's called vas deferens because, you know, we've heard of vasectomy that a lot of men have to deal with fertility. There's also something called the epididymis, which is just behind the testis as well, that helps with collection of the sperm maturation. And there's also some blood vessels in that area. There's veins and arteries. And sometimes the veins can get engorged. That's something called a varicocele. Sometimes you can get cysts in the epididymis at the back of the testis. These are sort of smooth structures. But the things that we're really worried about are hard, craggy structures that are on the testis itself, and are breaking through that smooth surface of the testis. They're irregular. That's what we want to know about. But I think it's best to really seek help with anything that you find. And a simple ultrasound scan is so easy to do and rule out anything serious.
And would you recommend the best time and place is often during a warm or hot shower when the muscles surrounding the scrotum are more relaxed?
Yeah, absolutely. Yeah, I mean, I think, getting into a hot bath or having a warm shower is a good way to relax everything, so that you can get a good feel around.
This is something I am ridiculously excited about, and I've been using it for a while now myself. We've all got wearables for our sleep, steps, heart rate, but the one thing we don't track, the thing that actually tells you more about your health than almost anything else, is your bathroom data. And that's why I joined the team at Throne Science. Throne is the world's first hands-free smart toilet platform that turns your everyday bathroom habits into real actionable health insights. It uses computer vision and sensors to analyze stool shape, color, consistency, frequency, even patterns like straining and time spent sitting on the toilet. And I've been helping to build out the science as well. No forbidden photos on your phone, no awkward Excel spreadsheets. You just do what you normally do, and Throne gives you trends that actually matter for your gut health, hydration, fiber intake, and even early warning signs you'd normally miss. If you want to be one of the early people to try this or just follow the journey, head to thronescience.com. That's thronescience.com. Trust me, it will be your gut's new best friend.
We've seen in other areas of medicine, and perhaps you tell me in urology as well, but certainly in specifically in radiology, breast radiology, we've seen significant advances in AI being used and being shown to be better at picking up microscopic, calcifications and possibly flecks of cancer than human radiologists. I guess there's still some way to go to, make sure it's accurate and not hallucinating certain things. But clearly, just from a pixels point of view, it's going to be better than a human. That's what, the research would suggest. Are there any ways in urology with regards to prostate health and testicular health that we can see AI being used, maybe from the genetic risk stratification, looking at, vagaries of PSA and just looking at trends and being able to, just cross-dimensionally analyze trends to give us useful outputs?
I think with tests, it's a bit difficult because the best way that we can diagnose or rule out testicular cancer is ultrasound. Yeah. And ultrasound needs to be done by a human being in a particular way, and there needs to be a sort of a dynamic adaptation to the way the patient is, the way the testis moves. It's a mobile structure, it's running around. You need to be able to...
Can never be replaced by AI.
I don't think so.
No.
Where I think AI is coming into some potential utilization in prostate is in interpretation of MRI.
Okay.
So the MRI images, and I know because there are some centres in the UK that are doing this, are being processed by AI algorithms, and they're being basically stratified very early on to say, well, there's no chance or there's low chance of cancer there versus there's a cancer here. And what that does is it helps you to be able to process these patients more efficiently and more rapidly within the patient pathway and focus the radiologist's attention, because radiologists are busy. Prostate cancer is a very common cancer, on the cancers on the MRI, that are most likely to be positive, to most likely to have cancer. That doesn't mean we're going to ignore the others. It just means that you can look at them further down the line. And of course, as the AI improves, we may be able to, at some stage, we think or we hope, say, actually, just let the machine do the work. The other point is that there are some algorithms in actually helping us to identify the tumor within the prostate. So it was called contouring, as it were. And that might be useful if we move towards a way of treating the tumors using, for example, robotics. So robots that work autonomously, that can work with an AI algorithm and treat the area of the cancer within the prostate gland completely autonomously. At the moment, it requires a human being to be able to focus the energy in that area. And
if you could change something that men do in terms of prioritizing their health, what would that be?
I think don't be afraid to ask for help. I think as men, we are sometimes frightened to come forward. I think perhaps it's associated with our own masculinity. We feel it's a weakness. We feel it's disempowering in some way to move forward, and seek medical help and seek medical advice, whether that's for our own physical health or for our mental health. I think it's really important to know that help-seeking behaviours is in no way emasculating.
No, I think this is a very crucially, important topic of health that, maybe seems on the back burner, but, clearly there's a lot of change that needs to be done in conversations, but also in diagnostics and treatment. And, I love that you're sort of, pioneering more research and trials in prostate cancer with the Transform trial, and interested to see, how that comes out. So eventually we should have finally a national screening program for prostate health.
We hope so.
Yeah. Professor Rajan, thank you so much for joining me.
Dr. Rajan, thank you.
Thank you.